Can we get going?
Yes, doctor. Please start, doctor.
Hi. Thanks, Ravi. Good evening, everybody. I'm Dr.Suresh, Shankar, nephrologist and
good evening,
Senior Vice President, Clinical Affairs at Nephroplus. And today evening, we have a webinar. Let me have the pleasure of introducing the speaker before I give a couple of putting that topic in perspective. Speaker today is Dr.Sreepani Gopaluni. He is a senior nephrologist and transplant physician at Citizens Hospital of Hyderabad. Dr. Sreepani has a pretty stellar career, as you can see on the slide. Completed his advanced training in nephrology in the UK. And I think it's not just that, he's tagged to institutions of repute, global repute, I would say, having trained in Oxford, Cambridge, and also has a PhD from the University of Cambridge in autoimmune diseases. I often see his name in social media conversations around immunology and where the crossroads of immunology and nephrology. And he continues to engage in his academic pursuits, as being on the editorial board of the International Immunology Journal and also in some of the leading kidney journals. And with 45 publications, I think he still carries the halo of his academic accomplishments. As for the topic he's going to talk today, he's going to be talking on hemodiafiltration. To the audience here, I think hemodiafiltration will rank among 4 or 5 interventions that are probably making the highest impact in ESKD care in India. The others may be ABO-compatible transplantation, growing number of disease donor transplantation across states. Of course, the improved access to hemodialysis through government programs. And then hemodiafiltration is the other advanced care that is growing. But in India, I think the growth is limited to tertiary care centers in the big cities and few and far around the country. And Dr. Sreepani holds that place, being in the select few. And he's there to share with us his thoughts, the learning curve, and his perspectives as to where we position this in kidney care in India. With that, let me invite Dr. Sreepani to commence his talk. Harry, you could change Dr. Sreepani as the host. And could I please request everybody to mute and feel free to share your questions on the chat box. We can take it at the end of the talk.
Thank you, Dr. Suresh. I think I'm still disabled from sharing my screen. Yeah, now I can. I hope you all can see my screen. You're able to see my screen, right?
Yes, Doctor. We are able to see.
Yeah. Thank you. Thank you so much, Dr. Suresh, for that profuse and kind introduction. As you rightly said, I think we are at a juncture of some significant developments in the field of renal replacement therapy. I mean, after decades of dialysis therapy, where we had not seen huge improvements in the mortality benefits of these therapies, I think we are entering this phase where the future is looking very promising. So we are now going to talk about this particular topic called hemodiafiltration. What's the latest? So we all are very well versed with the worldwide data about the mortality risks associated with chronic kidney disease and hemodialysis. So this graph on the left side is from US, where they have projected the expected life of a patient in a particular age group. For example, in the far left, you can see patients in the age group of 40 to 44. If they're healthy, they're expected to live for 30 to 40 years, as opposed to someone who is on hemodialysis. Their average expected life is unfortunately very low at about 10 years. And this is, it does not make a good reading, and rather it is grim. And this sort of remaining years of life sort of dwindles as they get older and older. So the major complications that we see in these patients are due to cardiovascular mortality. And the graphs on the right side shows the red one is the graph from the general population, where their risk of cardiovascular mortality is much less compared to someone who has had a kidney transplant, represented here in the blue line, or if they were on hemodialysis, it seems to be significantly worse. So the question here is, okay, we are providing the patients with hemodialysis. We are adequately removing their toxins. So why are they still not doing so very well? So just to answer this question, a few sort of clinical trials were conducted in the past. And the first of such studies is called HEMO study. This included a large number of patients, almost 1,800 patients. And this compared, okay, what if I randomize the patients to either low dose dialysis or high dose dialysis. Here, the dose of the dialysis is determined by a value called KTRV. Most of the nephrologists are familiar with this. And this essentially tells us what is the clearance of a particular molecule, represented here by K, times time, the time that they've been on dialysis, and it's been standardized to their volume. So they have chosen two different KTRVs. One is at 1.32, which is now considered to be the standard KTRV that is expected of all dialysis sessions, and compared this with a much higher KTRV of 1.7. And then they also factorize, this is a factorial trial where they have included also high flux versus low flux dialyzer. But unfortunately, this trial was a negative trial. There was no difference in the mortality, whether you use a high dose dialysis or low dose dialysis. But there are studies to show that very low dose dialysis is actually detrimental. So we should not be going for anything less than 1.32. And similarly, there has been no difference in the mortality when you use a high flux dialyzer or a low flux dialyzer. So this was rather disappointing. And then a similar study on similar lines called MPO study, or membrane permeability outcome study. This included a large number of patients, close to 740. This also failed to show survival benefit when you use a high flux dialyzer. So a lot of questions have been asked as to why are we not showing the outcome benefit that we are expecting. We are increasing the dialysis dose, we are changing the dialyzer membranes characteristics, but still there is no mortality benefit. And then people started thinking more about this to see, okay, could this be something more than what we're able to remove on hemodialysis? So then subsequent studies sort of shown that hemodialysis, especially low flux, high flux, is actually very poor in clearing some of the middle molecules, large molecular weight proteins or protein-bound solutes. And hence, there is a possibility that we're actually studying a wrong sort of parameter and assuming that is going to tell us the dialysis efficacy. So is KTRV actually slightly misleading in terms of predicting their overall mortality? Along with that, there are a number of other sort of issues, including a short daily dialysis schedule. So we only typically do 4 hours, 3 times a week. We don't have good control of the extracellular fluid volumes because assessing the dry weight is mostly an art rather than science. We don't have good control of the phosphates because dialysis is not known to get rid of phosphates as well as urea. So there are a number of other factors that may be involved in the outcomes. So going back to our physiology, so this is the diagram of a nephron. So this is the glomerulus. I'm not sure if you can see my cursor moving, but on the left, the glomerulus is where the actual filtration happens. So this is where the intraglomerular pressure sort of facilitates convective transport of solutes into the collecting tubules, and the diffusion occurs within the tubules. So far the hemodialysis has been concentrating on the diffusion element alone. and there's been no convective element. And is that the problem was the question. So this diagram on the right side shows a dialyzer with a semi-permeable membrane. And when you increase the pressure across this membrane, there is also convection as well as, and if you're passing dialysis through the dialyzer compartment, then the diffusion also happens. So what is actually convection? I mean, convection is nothing but movement of molecules or solutes through a semi-permeable membrane. And this is associated with the fluid that is being sort of driven out from one compartment to the other. So almost like a solute drag or a solvent drag, where the solvent, which is water in these cases, will drag the solutes along with it. And the water is being driven across the semi-permeable membrane by application of pressure. So that is what actually the convection here means. So there are a lot of trials that have happened in the past trying to understand if hemodiafiltration is any better in reducing the risk of mortality. Even though they have not been outrightly positive, but there is a very good signal to say that if you use a higher whereby this red dot, each red dot indicates the volume and the size of the study. And here they show that with increasing ultrafiltration volumes per session, there seems to be mortality benefit. And this benefit was shown to be only when the delivered convection volume was higher than 23 liters per session. We'll go through what all this means in the next few slides. So the most interesting outcome study was published only as of 2 weeks ago in New England Journal of Medicine. So this actually was a multi-nation clinical trial conducted mostly in Europe, where they tried to understand if adequate convective volumes on hemodiafiltration would lead to improvement in the outcomes of patients, especially mortality. So the patients that were chosen into this trial were all those that were receiving high flux hemodialysis for at least 3 months. And they were assigned to receive either high dose hemodiafiltration, or they were allowed to continue their conventional high flux hemodialysis. And the primary outcome here was death from any cause. So, well, this is a very positive trial in a way. So 680 odd patients were randomized to receive high dose hemodiafiltration. And another 677 were randomized to receive their standard high flux hemodialysis. They're all followed up for 30 months. And the delivered mean convective volume in this group is about 25.3 liters per session. And it did show that patients that were assigned to hemodiafiltration group actually had lower risk of mortality. So this is a very, very powerful and trial that confirms our earlier findings that high dose convective volumes on hemodiafiltration may actually result in improving the mortality. So further looking at these trials, there were a few other interesting observations that were made. So among those without any cardiovascular history, so that patient has never had any evidence of coronary artery disease, they actually had much they had much higher benefit when you compare to someone who has had cardiovascular disease. So it appears that this modality may be more suitable for someone who never had cardiovascular disease. It does not mean that patients who had cardiovascular mortality should be excluded from this, but this is an interesting observation. I don't think we have full understanding of the relevance of this particular observation. Further, it was also shown that patients that did not have diabetes mellitus, they tend to have better outcomes from hemodiafiltration. Again, the same disclaimer applies as the earlier description. We do not know the full significance of this. Even patients on with diabetes may actually benefit from hemodiafiltration. Interestingly, patients who received high-dose hemodiafiltration had actually lower infection-related deaths, including that of COVID. Again, this needs a much a deeper understanding as to what these observations actually mean. So this forest plot is essentially showing what I have earlier described. Patients with pre-existing cardiovascular disease, if they haven't had it, they tend to do better. Similarly, patients with no pre-existing diabetes tend to do better with hemodiafiltration. So this may give us an idea that young patients who are non-diabetic and who have end-stage renal failure, they should all be offered hemodiafiltration as a priority. So that's the theory part as to see why, we should be considering hemodiafiltration. We have conclusively shown with the latest trial evidence that this is actually beneficial in improving the mortality outcomes for our patients. So let's go into the practical bits of hemodiafiltration, or more or less nuts and bolts. So this slide is essentially trying to summarize the different renal replacement therapies that are available, excluding peritoneal dialysis and kidney transplantation. So on the left here, you have low flux hemodialysis, and then high flux hemodiafiltration and hemofiltration. And this graph below that indicates diffusion versus the element of diffusion and convection. So for any given QB or blood flow and the time that a particular patient is on hemodialysis, if they were to have low flux hemodialysis, then majority of the solute clearance happens through diffusion. And low flux hemodialysis is not so good in removing certain solutes. And as you can see at this on the scale at the bottom, low flux hemodialysis is very good in removing smaller solutes like urea and vitamin B12. But beta-2 microglobulin has been recognized to be associated with a lot of bad effects in these patients, and low flux hemodialysis does not get rid of beta-2 microglobulin, nor does high flux hemodialysis. There is some evidence that the high flux hemodialysis may be able to get rid of some of the beta-2 microglobulin, but not to the extent that a hemodiafilter can do. And hemofiltration, there is no element of any diffusion, and it's all convection. So the problem with hemofiltration is because there is no diffusion, the smaller solutes are not well removed on hemofiltration. So it looks like we found a sweet spot where there is diffusion element as well as convection element in hemodiafiltration. And so you can remove the urea and the creatinins, the smaller molecules, as well as the mid-sized molecules like beta-2 microglobulins when you use hemodiafiltration. So this is a brief schema showing what actually happens in hemodialysis. People, we always been very familiar with this. So the solute removal in hemodialysis actually happens across the semi-permeable membrane, across a concentration gradient. And this concentration gradient, the smaller molecules, they tend to move faster. And so they are better removed during hemodialysis. So the schema on the right side shows the blood that is coming out of a patient, which is full of these solutes. And at the bottom, you can see the fresh dialysate going in the opposite direction to the blood flow. So as the concentration gradient decreases because of diffusion across the membrane, in the hemodialysis, the terminal parts or the distal ends of the filter are virtually wasted because there is not much of concentration for the diffusion to happen. So this is what essentially in hemodialysis occurs. And it's good to remove smaller molecules like urea, but it's very ineffective in removing larger solutes such as beta-2 microglobulins. And then so there is actually a working group called the European Uremic Toxin Work Group, and they have so far identified up to 90 molecules, 90 compounds that are known to cause uremia. Of this, majority of them are of low molecular weight, so are less than 500 Daltons. So our standard low flux hemodialysis will get rid of them. However, there are almost 22 molecules which are of larger size, anywhere ranging between 500 to more than 12,000 units, of which beta-2 microglobulins is somewhere around 12,800. So an ideal membrane would allow all the solutes up to beta-2 microglobulin size and slightly beyond, but not albumin, because if you lose the albumin, that leads to nutritional losses. So it has been shown in multiple studies that the average clearance of beta-2 microglobulins in convective therapy is about 87 ml, as opposed to high flux dialysis, it's 49 ml. So there is a clear sort of winner here that hemodiafiltration would lead to better removal of beta-2 microglobulins. So This is a slightly busier slide, but I'll make this simple for you. The schema in the yellow box indicates that the one on the left is circuit of a hemofilter. The one on the right is circuit of a hemodiafilter. So let's start with hemofilter because it's easy to understand. So here you have a dialyzer, which is this big box with white and brown shading. And the blood of the patient comes through the top and then leaves through the bottom. And then there is a pressure that is applied across the semi-permeable membrane. And because of this pressure, there is a movement of water from the blood compartment into the outside through the semi-permeable membrane. Along with the water, the solutes here, the green ones here are the large molecular uremic toxins, and the purple ones are the low molecular weight uremic toxins. So they move into the effluent chamber and then they're filtered out. And this process where there is a lot of fluid removal across the semi-permeable membrane, if we don't replace this lost fluid, the patient will have a circulatory collapse and arrest. So we have to counter for that. And how do we do it? We substitute something called substitution fluid. So essentially whatever the water that is pushed out through the semi-permeable membrane, in order to maintain the circulatory volume, we replace it with sterile fluid called substitution fluid. So on the right side, this is a schema of a hemodiafilter. Here there are two different things happening. So there is a dialysate that flows in the opposite direction to the blood. Here, not only the convection because of the transmembrane pressure, but also diffusion because of the dialysate happens here. And again, the lost fluid in the form of ultrafiltrate needs to be replaced through substitution fluid. So the sieving coefficient of beta-2 microglobulin. So what is sieving coefficient? Sieving coefficient is nothing but the ability of a molecule to pass through the membrane unimpeded. So any molecule like a urea that sort of moves across the semi-permeable membrane unimpeded when there is pressure applied. And in convection, because there is no major role for diffusion, whatever be the size of the molecule, as long as it can pass through the membrane, it will be removed because of the convective pressures. So, so what is a convection volume? That's important because earlier trials have shown a convection volume of more than 23 liters is needed to achieve the benefits. And here the convection volume is the total ultrafiltration volume, which means it's the sum of the substitution volume. So whatever the ultrafiltrate came out, as well as the net ultrafiltration volume. So how much of fluid you are trying to remove for the patient, like let's say 2.5 liters or 3 liters that session. So that total together makes the convective volume. The dialysate fluid is not included in this as opposed to CVVHF or CRRT sessions where we also include the dialysate fluid in the calculation of the effluent volume. So, apologies. So here on the left here is a circuit of continuous renal replacement therapy. These are the conventional CRRT machines we use on the intensive care units. Here, the substitution fluid that you're seeing here in blue lines is supplied through bags. There are some issues, not issues, but there are some important considerations when you're comparing the conventional CRRT machine with the hemodiafilters. I'm not sure what these red lines are. Anyway, I will ignore them for now. So there are important differences here because the substitution fluid is coming from bags. The ultrafiltrate can only be limited in these patients. So for example, in a conventional CRRT machine, the ultrafiltrate that you achieve will be on lines of, let's say, 10 ml per minute or close to 800 to 1000 ml per hour. So because these are run for prolonged periods of time, let's say 24 hours, 36 hours, 72 hours sometimes, so that may not make a huge there may not be a huge issue because you are compensating for the lower ultrafiltrates with the time. As opposed to the hemodiafilters, where you want to do this in the OP setting. So everything has to be done within a span of 4 hours. So here we try to achieve much higher sort of ultrafiltrates, almost close to, as we said, the convective volumes of 25 liters or close to 6 liters per hour. In the context of a CRRT, because this sterile fluid is supplied through the bags, our ability is limited. As opposed to hemodiafiltration, this ability is much enhanced because of improvements in the techniques and technologies that have found their place in the last few years. And here, what we do is we take advantage of the ultra pure water that we are creating for dialysis as part of our dialysis program. So here you can see the purified water along with the concentrates are put through a ultra filter. So these are bacteria and endotoxin retentive filters. So they sort of grab the bacteria and the endotoxins, and then they are put through another filter so that they are made ultra pure and sterile fluids that are safe for infusion into the patients. And once these are made, then they go into either pre-dilution or post-dilution modes for further use. So here, I think the advantage of hemodiafiltration here is we are using a technology that is already there and available in most centers. We have almost got to the stage where this pure water is so sterile, they can be called ultra pure water. And on top, we are adding extra 2 filters in the machine that will make this completely sterile and pyrogenic free, such that they can be infused into the patients. So this is a simple diagram. I mean, it looks complex, but it's nothing complex. Here on the right-hand side, the blood from the patient is drawn, let's say 400 ml per minute, goes through the pump and through the dialyzer. And here you want to achieve a fluid loss of 5 ml per minute. But because of the ultrafiltration across this transmembrane, the TMP, we get about 505 ml, ultrafiltration of 105 ml. And along with that, the dialysate is about 400 ml. So together, this will be 505 ml. And we lose the 5 ml in the form of net ultrafiltration. And this other 500 ml is discarded. If you look at the dialysis circuit, the standard dialysis fluid goes through a dialysate filter, and then the same dialysate filter goes through another filter to make it the infusion fluid. And that 100 ml is returned back to the patient so that the net volume of 5 ml is achieved. So this line here, the gray line here, indicates the different measures that we had to take. This tubing has to be replaced with each treatment, and this is what we normally do. But on the left-hand side of this gray line, these are disinfected between treatments. Now, the hemodialysis machines are well equipped to automatically disinfect these filters after every session. And they also have alarms and signaling systems to tell us the time when the filter should actually be replaced. So what is an appropriate convective volume is an important question here, because you cannot do, let's say, I want to do 100 liters because it is good, or I want to do 200 liters, it is good, because there are some complications that we're going to see. So what is an appropriate convective volume is an important question here. So that is based on something called filtration fraction. So what is filtration fraction? Here, the amount of blood that goes through the filter and the volume that is filtered out. So that proportion is called filtration fraction. It was shown that a filtration fraction of more than 20% can be associated with a lot of problems, and that include excessive hemoconcentration, because you're drawing too much fluid out of the bloodstream, leading to hemoconcentration, and subsequently it will have knock-on effects on the patients. So it was shown that 20% is an ideal filtration fraction for most patients, and we should try and achieve that within our prescriptions. So there are different ways in which you can give the substitution fluid. As per the previous slides, you can see in this slide, either the fluid can be in the form of post-dilution, which means you infuse the fluid just before it enters the patient after it has gone through the processing in the dialyzer. The other way of doing that is giving the fluid before it enters the dialyzer. There are pros and cons to either of these. So let's have a quick review of those. If it is a post-dilution hemodiafiltration, the pros are there is high solute clearance and removal because you're not diluting the blood before it enters the dialyzer. So there is a very high solute clearance. And also because there is less wastage of the substitution fluid through the filter, you need reduced substitution volumes. And if you look at the pros of a pre-dilution, it leads to hemodilution because the solute concentration is reduced because of giving fluid before it enters the dialyzer. However, it also leads to reduced solute clearance because now the solutes in the blood are less in concentration, so the removal is less. So there are cons to either of these. With the post-dilution, primarily it's a hemoconcentration. When the blood is concentrated, there is more deposition of protein on the membrane, leading to something called membrane fouling. When the membranes are congested because of protein deposition, the sieving coefficient of this is reduced. So the ability to remove the solutes as expected is reduced. So there are pros and cons to either. Another thing of note here is you need high extracorporeal blood flow rates with post-dilution hemodiafiltration. And you need to have adequate anticoagulation throughout the procedure. Otherwise, there is a risk of a filter getting clotted. So a quick note on the purity of water for hemodiafiltration. As I said, this fluid is going to be infused back into the patients. It has to be completely sterile and non-pyrogenic. Otherwise, it can lead to microbiological contamination and leading to bacteremia in the patients. So the ultra-pure water is what we have been achieving nowadays. And that will have a colony forming units of less than 0.1 and endotoxin units of less than 0.03. And most units, in our units at least, we are aiming for a CFU count of less than 20 and a EU value of less than 0.5. And so because the fluid is going to be made on the go using the dialysate fluid, it's called online fluid production. And this will help us to have an unlimited volume of this particular substitution fluid. And because there is no storage involved, bacterial contamination is significantly less. And the cost of making this dialysate, substitution fluid is significantly less. This is just a schema of a particular unit where the dialysate fluid has been converted to hemodiafiltration as a substitution fluid. So the standard process of going through the filter, softener, activated charcoal, 2 RO membranes, and then there are additional microfilters along with 2 additional filters within the hemodiafiltration machines. So what are the clinical benefits of this high volume hemodiafilters? So a number. The main thing is we find, especially on my unit, I find that the hemodynamic stability is much easy to achieve. And this may be due to a number of different reasons, one of which is there could be some salt loading via substitution fluid administration. Also, you're infusing a lot of fluid into these patients, and that will reduce the core body temperature, leading to some hemodynamic stabilities. I have been using this in patients where we are having particular difficulties in maintaining their blood pressures on dialysis, especially in the context of despite trying various profiles that we have, like the UF profiles and the sodium profiles. And despite that, patients having difficulties to maintain their blood pressure, we are using hemodiafiltration. I recently had a patient where his only symptom was a steel type symptom in the fistula arm, even when the blood pressure drops to as low as 110. Okay, this was a patient where we had pretty good success, where we could use the hemodiafilter. The blood pressures have stayed rock steady around 130, and this patient was a happy man because he had no pain after a long time on hemodiafilter. And increasingly, we're also trying to use this in the context of ICU patients where the cost of CRRT is thought to be very high, or they may not need the continuous filtration that we want to achieve, and they need intermittent hemodialysis, for example, but their blood pressures are a little bit of an issue. So we've been trying to use this in the context of ICU patients, like a 10-hour or a 12-hour slide. We are using hemodiafilters. And We only recently started, and we have used this in a couple of patients recently, and we had pretty good sort of hemodynamic stability in these patients. And it also helped us to have better ultrafiltration that we were not able to achieve before. It has been shown to improve the quality of life because patients, one, they don't have hypertension episodes. Two, perhaps the removal of these middle molecules would make a difference in the inflammatory milieu that these patients are exposed to. And then because of the removal of the beta-2 microglobulins, it can lead to delay in the development of dialysis-related amyloidosis. Also, as I previously mentioned, there is loss of the inflammatory milieu or sort of amelioration of the inflammatory milieu. So it can lead to better anemia management, better plasma lipid profiles, and reduced inflammation. And as has been shown by the CONVINCE trial, it's been associated with reduced mortality risk. So there are some limiting factors when you're using this high volume online HDF. So the first and primary one is something to do with the blood viscosity. So patients like myeloma, patients who have hypertriglyceridemia, paraproteinemias, so their viscosity is very high. So in such patients, if you try to do hemodiafiltration, this may lead to clotting of the filter, and you have to immediately stop the hemodiafiltration because of hemo concentration that happens within the filter. The other thing is the filter performance as a limiting factor. So we should always be using a high flux hemodialyzer in these patients because the pore size has to be big enough for the solute drag to happen. And you can increase the surface area of these membranes for better sort of ultrafiltration rates. So the other thing is blood flow as a limiting factor for high volume HDF. So it's expected that the patients will have a good access for them to go into hemodiafiltration, and typically anywhere between 400 to 600 ml per minute of access flow is needed. And in the pediatric patients, about 5 to 8 ml per kilo is what is expected. The current hemodiafilters machines are so sophisticated, both hardware and software wise, they're able to adjust the ultrafiltration rate depending on the blood flow. So otherwise, you're trying to achieve a convective volume of 25 liters and the blood flow is not adequate, and then you end up with multiple alarms. So what it does is it sort of cleverly balances out the amount of fluid that is being drawn out and the amount of ultrafiltration. So if the fluid that is coming out of the axis is low, then it reduces the ultrafiltration. And at times when the blood flow is high, then the ultrafiltration volume is increased. So it is sort of cleverly designed to achieve the convective volume that you are looking for without compromising the safety of the patients. I'll just ignore that. So in summary, I just want to conclude by saying patients on dialysis have higher mortality risk compared to general population. Hemodialysis is associated with inadequate middle molecule clearance, and this may in turn be associated with increased mortality and poor quality of life. Convection is associated with better clearance of these middle and large molecule clearance. A meta-analysis and a recent CONVINCE trial, which was published 2 weeks ago, they have confirmed the mortality benefit associated with HDF. And this benefit is more pronounced in patients without comorbidities of cardiovascular disease or diabetes, though this has to be taken with a pinch of salt, and we need more information on this. And ensuring high quality, sterile and non-pyrogenic fluid via online filtration process is of paramount importance. This is becoming easier and easier with improving technologies, both hardware and software wise. With that, I'll just conclude and open the sort of, I'm open for questions.
Thanks, Sr.Consultant, for an excellent talk. I think very lucid in terms of the mechanics at the back end. Maybe there's time for questions. I'll read off some from the chat box. Interesting context for cost-sensitive. Maybe we have to practice. Somebody has Ravia Hazuria. There's a question. Is it best to do hemodialysis twice a week and hemodiafiltration once a week? It's kind of a hybrid way of dialysis. What would your...
Yeah, I think That question is difficult to answer because we don't have any data to support or refute that particular hybrid mode. But if you look at the trial data, obviously it is for 3 times a week, all sessions using hemodiafiltration. So, well, we can logically sort of extrapolate, saying that having beta-2 microglobulin, less of it, is probably better than having more of it. So other than that, I mean, if you're looking for a clear-cut evidence-based answer, we don't have one. But I think something is definitely better than nothing, is what my take would be. I'll be open for your views, Dr. Suresh.
Let me first go through the questions, then we'll kind of have the discussion.
Yeah.
Somebody else has a question on, for heparin-free patients aiming to achieve target urea clearance, would you consider PreDilution HDF or a hemodialysis mode with intermittent flushing?
So I think this question, if we carefully dissect this, so the question is, if it is heparin free, okay, so you don't want to give any heparin for these patients. So when we're not going to give heparin, always it is better to go for PreDilution HDF. It's just because you are reducing the viscosity or the hematocrit of the blood that is flowing through the dialyzer, which means the clotting, the red blood cells coming together, the chances of them coming together within the filter is significantly reduced. So that will lead to better if not efficiency, but preservation of the filter from getting clotted. However, we should also take note of the fact that because you're diluting not only the red cells, but also the solutes, which means you need much higher convective volumes, almost twice that of what is needed in the post-dilution mode. So the trial, the CONVINCE trial, they have used 25 liters in the post-dilution mode. It is not in the pre-dilution mode. In such cases, for the pre-dilution mode, you have to almost double your convective volumes. Almost you have to go up to 50 liters. Otherwise, you will not have enough solute clearance. So you may be compromising on that if you go for lesser ultrafiltration volumes. So definitely pre-dilution if you're not going to use heparin. So the other question is, you said, or the other option you said is hemodialysis mode along with intermittent flushing. So intermittent flushing may not work in the context of hemodiafiltration because this is a very sophisticated piece of software using quite a lot of algorithmic adjustments to the blood flow and the infusion fluid, substitution fluid. So you can give some, but it may upset the software algorithms.
Yeah. No, it is actually about intermittent saline flushing for regular dialysis.
For regular dialysis, absolutely, yeah.
Somebody has a question asking, when writing a prescription for a patient for HDF, what are the variables that we can control to control a ECV of 25 liters? Yeah,
that's a good question. So
I think in Indian context, blood flow rates are a big challenge, right?
Absolutely, sir. Absolutely, yeah. So the first question, so if you look at the prescription of hemodiafiltration, so one is obviously the convective volume that you want to achieve. We should also achieve the standard KTRV of 1.2 because you should not ignore the small molecule solute clearance. So that is one thing which you would normally do. So you should also focus on trying to achieve it. Here, the different parameters are obviously the blood flow rate. So you want to have at least a minimum of 350 to 400 ml per minute. And then if it is a pediatric patient, as I said, 5 to 8 ml per kilo body weight is what the blood flow rate you should be achieving. The other thing is you have to set in, I need a convective volume of 25 liters. And most of the other mechanics that are involved in this are taken care by the software. So the software will adjust the TMP across the membrane. It will adjust the substitution fluid, the ultrafiltration rate. It will adjust the infusion fluid that is required. So I think there is a particular piece of software called AutoSub, which is used in these Fresenius machines. It's the most sophisticated piece of equipment where it carefully titrates everything that you're doing to achieve the desired desired convective volume. So sometimes, I mean, this is what we expect, but you may end up with slightly less convective volume.
Questions around limitations or adverse effects. Have any patients experienced allergies to HDF mode? And I'll add one other question. Do you have experience about patients having headache during HDF and any specific cause?
Okay, okay. Yeah. Have any patients experienced allergies to HDF mode? So I think if you look at the allergies, most of the allergies we may find in our dialysis patients is to the membrane, the polysulfone membrane that we use. And I find, I mean, maybe my coincidence or not, most of the patients on the dialysis, they tend to have mild eosinophilia. And I have always attributed this to the polysulfone membrane. And I could not prove this or disprove this. And because we are not using any, I mean, the filters are exactly more or less similar lines to high flux dialyzers, I would not expect any allergic reactions to the dialyzer itself. But the problems will come with the quality of your dialysate and the infusion fluid. If your methods of ensuring the sterility of the fluid are at fault, you will have definitely either an endotoxin related adverse events or bacteremia. So it is of paramount importance that you check the CFU and the endotoxin levels in your dialysate fluid every 2 months, as well as in the substitution fluid that is produced through this machine. And other than that, I don't see any specific reason why they should develop any specific reactions to this. Hemodiafiltration, paradoxically, may be less in these patients because you have better hemodynamic stability. And most of the times, the headaches that we tend to see in these patients on hemodialysis due to rapid shifts of the fluids. That may still be the case, but I don't have enough sort of experience of patients who had headaches on hemodiafilter so far.
Someone else had a question on what is the main cause that we may not be able to achieve the 25 liters convective volume in a post-dilution HDF?
I'm sorry, what are the main cause cannot achieve?
What are the main causes that limits us achieving the 25 liters convective volume?
I think it primarily depends on the blood flow rate. That's one thing, because if the blood flow rate is not so good, you will not achieve the ultrafiltration that you're looking for. And the second thing is the hematocrit of the blood. The hematocrit is very high. For example, someone who has got a hematocrit of 50, 52, 53, then it is dangerous to put them on HDF because one, the filter gets clogged and the TMP goes up significantly, leading to reduced ultrafiltration and reduced convection volumes. Especially in the post-dilution mode, there is something called membrane fouling. This is where, as the ultrafiltrate happens through the filter, the protein molecules, the concentration of it goes up and they starts blocking the membrane pores. And when this happens, the transmembrane pressure rises and leading to reduced ultrafiltration as well as reduced sieving coefficient for a number of molecules. So I think the first thing is the access flow rate, and the second thing is the hemoconcentration, and third thing I would think is increased blood viscosity if a patient were to have it.
Okay, I think, wouldn't you think in the Indian context with our hemoglobins relatively in the lower range, that shouldn't be a problem, right?
That should not hopefully be a problem. But there are obviously other proteins that can lead to hyperviscosity. So it's probably less, I guess. Yes, you're right.
And blood flow rates, are you able to achieve 300 plus more often than not?
More often than not. So we got to carefully choose our patients here too. So so far we have used it only on patients with fistulas. I think the challenge will be when you use the lines where you may not be able to achieve such high flows.
Do you have patients on tunnel catheters who are on?
I'm sorry?
You have patients who are on tunnel catheters who are on?
We dialyze one patient on a tunnel catheter.
There's a question around sodium modeling and isothermic in HDF? Do you explain?
I think I'm sorry to say that's beyond my current knowledge. I had to pass this because I don't think I'll be able to.
I think I would comment either, so I will confess my ignorance. So any other questions from anybody else? We still have a few moments.
On how many months does HDF typically take? There was in the chat one, there was a question on that.
How many months on HDF before we start seeing good results?
Correct,
I suppose
correct.
this person is talking about the symptom benefit that the patient may accrue, right? Because
yeah. I think we're too early into this to confidently say how many months we need. And unless you do a fully controlled clinical trial, there is absolutely no way of knowing whether you're benefiting the patients or not. I think because in our day-to-day clinical practice, there are so many variables that we cannot control for. And it's not like paracetamol that will just relieve your headache and you know it is working. So I think we unfortunately have to rely on further clinical trials where you correct for all the noise that is there, without which I think the clinical experience will have to go with the trial data that is available. And I think as we keep accruing our knowledge, I think it may be well over many years before we actually know, yes, patients on hemodiafiltration are actually doing better than someone who is not.
Yes, I agree. There's one question on diet, Doctor. It says change in recommendations of protein intake for HDF.
Correct. I think that's a very good question because there is definitely some loss of nutrition or excess loss of nutrition in the hemodiafilters because you're using bigger ports and you're forcing out most of the solutes out through the hemodiafilter. So this recommendation has been that these patients should be advised to take slightly high protein diet, even though the quantification as to how much they should be should actually be based on the protein catabolic rate for us to carefully recommend. But certainly there will be some loss of protein using HDF, saying that the albumin levels in the CONVINCE trial, pre and post trials, they were no different. They were still in the normal limits. The other thing there is loss of water-soluble vitamins through this. So all these patients should be receiving water-soluble vitamins as part of their routine prescription.
Thank you, Doctor. There was a question on adequacy. Do you still use KT/V as a parameter of adequacy when you do HDF or any other parameter? And do you check beta-2 microprotein in your patients? Okay, so there are two different clearances that we have to use when you're assessing the adequacy of hemodiafiltration. Definitely one is the standard KTRV of more than something like 1.3 as per the KDOK guidance. It's just because we should not lose sight of this small solute clearance here in these patients. And there's nothing to worry about not achieving a KTRV of 1.3 because the diffusion happens as routine as in a hemodialysis filter. So the other parameter that you are obviously looking at is the convective volume, at least about 25 liters in the post-dilution mode, or in the range of 50 in the pre-dilution mode. So these are the two parameters. I mean, certainly you can use beta-2 microglobulin clearance, but there is no data to support that such a measure is actually helpful in understanding the mortality benefit or risk. Okay.
Yes. There's someone, Kumar Sambhav Varma, who's on the webinar, who's put in his experience. I'm on HDF dialysis from last 3 years and used FX800 and FX600 4DX for 3 to 4 months and started getting headaches after dialysis. Now, normally I was using FX60 4DX and I didn't have any issue. It's just a comment.
Yeah. I mean, I have not had any experience using FX800 or 600. I don't know if any of the technicians would be able to chip in with an answer here.
Headaches. Yeah, this seems to be kind of something above our knowledge level, which we'll have to go to global experts to address.
Yeah. I'm sorry, I don't clearly know.
The question around HDF, will it help for kidney transplant? I mean, potential kidney transplant recipients. I guess it's no different.
I think, yeah, it is a different dialysis modality, really. And certainly it will not impede someone from getting a kidney transplant. Will it help? I mean, it may make them feel a bit better. It may reduce the inflammatory milieu. It may have better benefits on their lipid metabolism, and it may maintain their hemodynamic stability, which in turn will maintain their cardiac outcomes. So yeah, I think all in all, I can only see benefits rather than any disadvantages of using this.
Someone who just has a comment saying, I mean, kind of question. Is there still no strong evidence demonstrating the superiority of HDF in comparison to high flux hemo, as theoretically expected? Why?
I think, I think theoretically is all we can go, because we don't have a clear explanation. So as previously mentioned, the outcomes of patients on hemodialysis or renal replacement therapies depends not only just the clearance of the solutes, but a number of other factors. For example, the volume. Okay, if we get our dry weights wrong, okay, so these patients are chronically overloaded. So however hard you try to ultrafilter and achieve the convective volume, you still are overloading a patient and causing cardiac morbidity. Not only that, there are a lot of protein-bound solutes, which we cannot remove them because they are protein bound and protein doesn't get through past the membrane. And these solutes, we still don't know how much of an adverse effect they will have on the overall outcomes of these patients. And as I said, there is this uremic toxin working group, and then annually they're finding newer and newer toxins that we still don't appreciate the role of in terms of determining the outcomes. So I think it's there are a number of different factors in addition to just removing the solutes, and this is all what we know and what we can easily achieve is what we are trying to demonstrate here. So a lot is still unknown as to why this mortality is so high.
I think if you have to position this therapy in the context of India, right, how might you do it? I mean, in terms of select few who might get the maximal benefit.
I think at least for now, there are different aspects we need to consider here. One is the financial side of things, because these therapies are costly, much costlier than what it would cost for a low flux and a regular hemodialysis. So that becomes the first constraint in terms of who you would choose, even though unfortunately that should not be. Okay, but that is the real reality in India. So the second constraint I would look at is patients who are younger, I believe, should be offered this, given that they are likely to be on some form of renal replacement therapy for longer. So we should do everything to try and protect their cardiac status, protect their brain, protect their blood vessels and everything. And this we may be able to achieve to our satisfaction, younger patients. It's only primarily because we are trying to also rationalize the use of 1 or 2 hemodiafilters that we have, and this will probably change in the future as we go along, as we acquire more and more of these machines, and we may be able to offer it to the entire gamut of the patients that we have. The other patients I would choose to offer this would be patients who have significant hemodynamic instability, because each time an episode of hypotension occurs, it is going to have a knock-on effect on the heart. It is going to cause myocardial stunning. It's going to cause increase the cardiovascular morbidity in these patients. So such patients where you're struggling to achieve that fine balance, I think these are the patients you should prioritize in using this hemodiafilter.
I think if they are to stay on dialysis longer without a transplant, I think I think the long-term morbidity issues, particularly musculoskeletal, potential. Any other questions? Or else I think we're on time. Kamal, did you have any other questions?
No, nothing from my side. Thank you so much. Thank you so much, Dr. Sreepani. It was a lovely webinar. Thank you so much. Thank you so much, Dr. Suresh, for moderating it. And we hope to do more such webinars in the future as well.
Thank you. Thanks for the opportunity. It's fantastic associating with you.
Thank you.
Thank you.